Hello? Allô? Merci beaucoup. Je ne peux pas parler français. Distinguished delegates, esteemed guests, ladies and gentlemen, I'm Daniel Piñeiro. I'm the current president of the Heart Federation. It's my immense honor and pleasure to welcome you on behalf of the Heart Federation and the National Heart Foundation of Australia to our event, Break This Cycle, Act the End Rheumatic Heart Disease. Tonight we joined forces to address a critical yet often neglected condition. Rheumatic heart disease remains a major public health challenge. It affects more than 40 million people worldwide, with a disproportionate impact on children, adolescents, and young women. Last November, we convened our first ever World Congress in Rheumatic Heart Disease, reaffirming our commitment to reducing its global burden. The unanimous adoption of the resolution of the World Health Assembly 7114 on rheumatic fever and rheumatic heart disease in 2018 was a significant milestone in our journey. And once again, I wish to express our gratitude to the governments who will speak today, including Australia, Egypt, Tunisia, Indonesia, the Philippines, Zambia, and Malawi, for their instrumental role in the adoption of the resolution. Since its adoption, however, its implementation has faced many challenges, and urgent action are sorely needed in many countries and regions. The elimination of rheumatic heart disease within a generation is not just an ambitious dream, it's an achievable goal. To the right intervention and dedicated resources, it can become a reality. I encourage each of you to reflect on our upcoming debates and find ways to further share knowledge, mobilize resources, and forge partnership to break the cycle of the rheumatic heart disease. Together, we can act and spread ahead initiatives to eliminate rheumatic heart disease and once and for all, and ensure cardiovascular health for everyone. Thank you so much.
Daniel, thank you. Thank you very much indeed for that introduction, and a very warm welcome to you all from me. I'm Shuli Ghosh, and it's my honor to guide us through tonight's conversation on the actions needed to end the suffering caused by rheumatic heart disease. We are going to hear from ministers, from policymakers and health experts. We're going to discuss the progress of global policy frameworks and explore how to secure the resources needed to successfully tackle and eliminate rheumatic heart disease. We know the need for progress is paramount. As we've heard, combating the disease remains severely under-resourced despite a WHA resolution. So here to give us an overview of some of what the WHO is doing in this field, I'm very pleased to introduce Dr. Anshu Banerjee, Director of Maternal, Newborn, Child, Adolescent and Aging Health at the World Health Organization.
Thank you very much, and it's a pleasure to be here, but at the same time also actually it's very sad to be here because looking at rheumatic heart disease and rheumatic heart fever, this should actually be a preventable disease. With proper primary health care, we should be able to identify rheumatic fever early on and be able to treat it, as well as for skin diseases that are caused by group A streptococcus. So I was very interested to hear, and I'll come back to that point about elimination, and I'll say something about that at the end. But the fact that we still have 40 million people, as mentioned, who are affected with rheumatic heart disease, and also having 300,000 people who die annually, it's shocking. and totally preventable. So what has WHO done? We had a resolution in 2018 that put rheumatic heart disease on the agenda, and I would actually like to thank the government of Australia, because I think you were the leader in that, to raise it and put it on the agenda. And so after that, we've been working on developing a guideline, and I think Bernadette will say a little bit more on that during the panel discussion. But the guideline is looking at 3 areas. First of all, primary prevention, so how can we better prevent, detect, and manage Group A streptococcal rheumatic fever and rheumatic heart and Group A streptococcal skin disease. Secondly, it's looking at secondary prevention and how do we better manage recurrent infections with long-term antibiotics. And we have struggles, we have challenges there because it's not available in the market. It's not interesting for companies to actually produce it. So we have a lot of challenges around this area. And we're also looking in the guideline around how we can better manage rheumatic heart disease, and particularly looking at how to use anti-inflammatory drugs to sort of address rheumatic heart disease. Our regions have also been working on this. In 2019, our region for the Eastern Mediterranean region has developed a framework for action to see how they could take this forward, and that was endorsed by the regional committee. So it's really a document that also served as, I think, an example for other regions and for us globally on how to put a framework together. We also have examples from our Western Pacific region, where some of the countries which have a high burden have put up registry programs so that people can be registered and follow up. Because that's one of the things, patients are identified, but do we have proper follow-up with long-term antibiotics in order to be able to assist them? And of course, we should also look at maybe some of the innovations that are coming out. So, for example, we have handheld ultrasound, and that could be used both during pregnant women and to look at progress during pregnancy and identify the age of the gestational age of the child, but at the same time it can be used for other diseases as well as for rheumatic heart disease. And of course we hope that in the future we'll also have a vaccine that could help us prevent Group A streptococcal infections. But none of this can be done without partners. It's really, moving forward should be done in partnership. As WHO, we work together with UNICEF, with the World Heart Federation, with REACH and other partners in taking this forward. And I think that's also the reason why we're all together here today, in order to see how can we jointly take this agenda item forward and make sure that, this will be a disease, well, an eliminated disease, let's say. And I just wanted to reflect a little bit on the elimination goal, because a couple of years ago, we were thinking the same about cervical cancer, and we looked at, is it possible to eliminate cervical cancer? And we said, yes, it is possible. And so the first thing to do is to sort of identify what is your threshold, let's say, because it's not eradication, it's elimination. And so you'll have to think through how you define elimination. And for that, it would be important to do modeling and also to see how soon, let's say, we could eliminate rheumatic heart disease. When we did that for cervical cancer, it was still far away. For cervical cancer elimination, we sort of thought that we'd be able to achieve that elimination goal globally by 2070. But it did galvanize partners around the idea of having to put this onto the agenda, and particularly also partners who are working in the area of HIV sort of said, why are we investing money in managing and identifying, diagnosing, treating women with HIV if 5-10 years down the line they die because of cervical cancer? So there is a human rights angle to this that we, I think, need to keep in mind. It's a disease of poverty. If we truly believe in the SDGs that we should leave no one behind, this is a disease that we need to tackle. And I do think that the idea of having an elimination goal is a way forward in order for us to raise the profile of this agenda and galvanize the community around it. Thank you very much.
Thank you very much indeed for that overview. So I'd like to introduce someone now who knows only too well firsthand the consequences of failing to tackle rheumatic heart disease. She developed rheumatic fever, which damaged her heart valves when she was just 11 years old, and she now shares her experiences as part of her work as an NCD advocate. Please join me in welcoming Anu Gamanju from the NCDI Poverty Network in Nepal and the Global Alliance for Rheumatic and Congenital Hearts. Come on up.
Thank you so much. Thank you, Shuli, and then the World Heart Federation, National Heart Foundation of Australia for this wonderful opportunity and this platform for me to share my lived experiences. And it's wonderful to be a part of this discussion because we are talking about eliminating rheumatic heart disease, and we are talking about 40 million people, and also those who 300,000 people who have lost their life because of this preventable condition. And I could be one among that 300,000 people because I had the congestive heart failure, and also I am in that 40 million people, and I'd like to share my lived experience. Yeah. So many of you might know the signs and symptoms of this, but for me, it started when 23 years ago, I had this continuous sore throat, which me and my family thought it was a normal process, and we opted for homemade remedy, and we didn't think about the necessity of having an antibiotic on a proper days and a proper dose. So it affected me eventually to rheumatic fever, and it increased to rheumatic heart disease. The time when I got diagnosed was very late because the very day I was in the hospital for this treatment, this diagnosis, I was referred to the surgery unit to have my mitral valve repaired at the age of 11. As a child, I didn't know anything about my condition that was making me weak physically and also emotionally and psychologically, because I lost the opportunity to be with my friends, play with them the same way that they do, or do the activities that I wanted to do because I was weak, physically lean, and also very much low-stemmed. But after the surgery, my first surgery, where my mitral valve was repaired with a ring whose name is a little bit similar to my name. It was annuloplasty ring. So I never forgot that name till today. And so it helped me recover from the physical pain, but also there were moments where I felt emotionally and mentally very low. Even for my parents who bared the cost for that surgery, it was a huge thing for them, because there was no saving for them to invest in my heart operation. My parents, they went to seek the loan from neighbors, and they were at times discouraged and they were told that, what are you doing? Are you in your right mind of state, because you are seeking loan to treat your daughter, not son? If I were in your place, I would have done for my son. So, but I'm really, really thankful to my dear parents. They didn't listen to them, but they took the loan and invested on my health. And after my first heart surgery, I was able to continue my education and do my undergrad also in the public health sector. But it was not an easy journey. 15 years later, I needed a second surgery where the doctors told me that I needed that repaired valve to be replaced with another valve. And I was given options to choose between mechanical valve or biological. It was really difficult for me. I didn't know what is that, but I'm given two options that has lifelong impact and other associated things that I need to take care of, the medicine and the cost the huge cost that I had to bear with. But also another thing is, during that period, I had to lose my job because I was not physically fit to be actively involved in the respected expected responsibilities. So it was really difficult for me and my parents. But still, I had the second surgery. I have a mechanical heart valve, and if it's possible, I would like to like all of you to listen to the heart valve that clicks each and every second like a switch of the clock. And it is sometimes interesting to listen to that, but sometimes it is really frustrating, and it threatens me when I have this palpitations, that my heart rate goes up to more than 50, and at that time I feel like I'm having a time bomb inside my body, and it is really frustrating. But I'm glad that all these bad, worse, and sometimes good experiences living with rheumatic heart disease have led me to this platform in front of you, doing advocacy, speaking my experiences, not just for me, but for all the 40 millions that we just mentioned. And there are other many vulnerable populations that we know in the areas that we are working for, and there are a lot to be diagnosed or screened, and we have the opportunity to protect them, prevent them from going all the challenges that I just briefly mentioned, because 23 years of living with that, not just 23 years, 23 times something seconds, it is really a challenge. And we all are here to address this challenge. We need to think about who have already been diagnosed with this, are living with this, and who are vulnerable. And in that journey, I got the opportunity to be a part of advocacy journey through the involvement as a Voices for Pain Plus with the NCDI Poverty Network, as well as WHF, and also the WHO, by being involved in developing many aspects like the meaningful engagement of people living with NCDs, mental health, and neurological conditions. And also, in that journey, I got the opportunity to meet with other many wonderful health lived experience experts, because and also they are from all the 6 regions of this world. And while I work with them through the Global Arch, Global Alliance for Rheumatic and Congenital Health, so what I learned is, it is not just my own problem, and my problem is sometimes smaller or sometimes bigger than others, and we all share the same hope to be able to receive the equal and equity care at the universe, like the theme that we follow from the universal health coverage. So it is what we need, and also to be involved in every discussions or every interventions that we do in the countries at the local level, because it is all these are for the people who are living with this condition. And we are resourceful with our experts, and we will be able to help you in other sectors, in every sectors that we discuss about, not just particularly in RSD, but also Dr. Ansu mentioned maternal and child health and mental health and other NCDs in every, and also communicable disease aspects also, because we all know how people living with NCDs, including CVDs, were affected during the period of COVID-19. So yeah, I would like to just, even though I want to share a lot, but I would like to conclude with a request that we should be working together, and please let us be a part of you, because we are all here together for the same cause, for the 40, not just for the 40 million, but all the people living in this world. Thank you.
Thank you so much, Anu. Well, despite the fact that RHD has been eradicated in many parts of the world, it is still prevalent, as we've heard, among children and adolescents in low and middle income countries. And in high income countries, it's found among immigrants and indigenous populations. So let's now get the perspective of some of those countries which are committed to tackling the disease. To start us off, I'm pleased to introduce His Excellency Mark Butler, Minister of Health and Aged Care from Australia.
Thank you so much, and thank you, Daniel and Anshu, but particularly thank you to Anu. No, you're such a terrific advocate. No wonder they named a heart procedure after you. But the network in Nepal is absolutely very lucky to have you. So thank you for joining us and reminding us that for all of these debates, the experience of patients and consumers like yourself always needs to be utterly at the top of our considerations. I have the enormous privilege of being a minister in a government of a big country that's very wealthy and is home to the oldest continuously surviving culture on the face of the planet, the Aboriginal and Torres Strait Islander people who have been on those lands for at least 60,000 years. And it's a great privilege, but it's also a great responsibility because the gap in health outcomes and life expectancy between Indigenous Australians and non-Indigenous Australians is enormous. And it's in some areas not improving, and even worse, in other areas, it's actually a growing gap in some critically important health areas like cancer and so on. And rheumatic heart disease and acute rheumatic fever is in Australia a microcosm, I think, of the deep inequities in health outcomes, life expectancy, all of the opportunities that good health affords individuals and communities right across the world. As I said, we live in one of the wealthiest countries in the world, and for the vast bulk of our community, rheumatic heart disease is unknown. Most doctors in our cities, the vast bulk of doctors in our major cities, would likely never have come across a case of rheumatic heart disease. My auntie, who would be in her early 70s, contracted acute rheumatic fever in her teen years in the 1960s, which was not uncommon back then, but she was really one of the last generation of non-Indigenous Australians to experience ARF and certainly RHD. She's lived with cardiac complications all of her life. But for Indigenous Australians, particularly those living in remote communities, they experience some of the highest rates of acute rheumatic fever and rheumatic heart disease on the planet. And so for us, it is a striking example of the responsibility we have as a nation to close that gap in health outcomes. As I said, it's a gap that we see right across the spectrum of health. But rheumatic heart disease, a condition that has essentially been eradicated in non-Indigenous communities in Australia for 50 years or more, is one of the most striking examples of that deep, enduring inequity in health outcomes that exists in Australia. And that is a microcosm, as has been said already, of the global inequity, that this is a condition largely preventable that is really not seen in wealthier communities anymore, hasn't been for some decades, but remains a huge burden on individuals and on communities in lower and lower middle income communities as well. That really is why Australia has been such an active participant in the original resolution around this condition and in activities and events like this. It's a reflection of our failure as a country. It's a reflection of the ongoing inequity in our own country, our determination to deal with that inequity in our own nation, but to see some of the lessons that maybe we can learn also drive global and international behaviour. We also work very closely with what we describe as the Aboriginal community controlled health sector. Dawn Casey, who is the driving force, particularly in this area, for that sector, would love to have been here today. She's an active participant in global health affairs broadly, particularly from a First Nations or Indigenous perspective, but particularly in this area as well. And she would very much have loved to have been here, but she can't join us from Australia today. And we work very closely through investment in prevention, but obviously, as Anu has said, to deal with the ongoing treatment responsibilities that we have for very significant numbers of Australians, overwhelmingly Aboriginal Australians who now live with this condition from a very young age. And that's a substantial investment that we should and do continue to make with that community. I also want to speak very briefly, though, about the engagement we have with our Pacific neighbours. Pacific Islands, small Pacific Islands in the region we are part of, also have some of the highest rates of rheumatic heart disease on the planet. And we work closely together as governments and as health organisations. You're going to hear from Jonathan Karapetis from the Telethon Kids Institute in Australia. This partnership is a really important element of a multi-layered, very comprehensive partnership we have with our neighbours in the Pacific. And today I want to announce that that on behalf of our government, we will be investing a further $5 million in a partnership with the University of Western Australia and the Telethon Kids Institute, from whom you will hear later, to support that Pacific RHD response. Those partners already have very significant experience working with RHD control programs in Australia and in New Zealand and in Fiji. They've supported very notable progress in screening for RHD and also improving adherence to prevention measures. And the investment I announced today will establish a regional RHD knowledge hub in Fiji that will act as a central point for resourcing, for technical expertise and knowledge sharing right through that region. The program aims to lay the foundations for effective, sustainable and equitable RHD control programs by working in partnership not just with Fiji but also with governments in the Solomon Islands and in Vanuatu as well. We think this will deepen the relationship we have in that region, knowledge sharing and capability building, but also help to contribute to the lofty ambitions, the important ambitions of this event and of organisations that are represented here today, particularly the Heart Foundations, in ending RHD over time. This is an important and achievable goal and a really important signal for dealing with some of the gross inequities that continue to exist in our global communities and frankly within nations like ours of the global community as well. So thank you to the World Federation and to the Australian Heart Foundation, to David and your team with whom we have such an important and productive relationship. Thank you for organising this event and for inviting me to say a few words, and I wish you all the very best for the rest of the event and the week at the Assembly. Thank you very much.
Thank you very much indeed, Minister, for I think that very honest appraisal of the situation in Australia. Now, we are also hoping to hear from His Excellency Khaled Abdel Ghaffar, the Minister of Health and Population in Egypt, and also His Excellency Ali Mrabet, the Minister of Health in Tunisia, who are on their way. So when they arrive, we will, of course, ask them to say a few words on the situation in their countries. But let's turn to a wider discussion now on the challenges of eliminating RHD, and we have not one but two panels for you. I know you're excited. Let me introduce the first panel to identify what's needed to turn the WHA resolution into concrete advances. Please welcome, first of all, Dr. Jerna Manatad, Director of Disease Prevention and Control Bureau at the Ministry of Health in the Philippines. Thank you. And that microphone is yours. Professor Fastone Goma, Ministry of Health in Zambia. Thank you very much. And Dr. Nita Chinyama, the Deputy Director of Curative and Medical Rehabilitation from the Ministry of Health in Malawi. Oh, excellent. Okay. I appreciate they're not the most comfortable seats to sit on, but if you're all right to just hold your positions for a few minutes, we're very pleased to say that His Excellency, the Minister from Tunisia, has arrived. Although how he will feel about walking straight in and then starting to talk, I don't know. It's a bit of a test, isn't it? Shall we start the discussion and let him catch his breath? I think that's probably best. I'm going to take a seat here as well. I'm going to speak to each of you in turn to just get a better understanding of what's going on in your countries. And I'm afraid you'll be sharing a microphone. So let's start with you, Jenna. The Philippines has made significant strides in healthcare delivery in the past decade. So tell us some of the initiatives which have had an impact on RHD.
First, I would like to say thank you for inviting the Philippines to be engaging with all of us here today. With us is our Assistant Secretary of the Department of Health, also with me. And the aspiration of the country really is to bring a better health for all Filipinos. And that's a common aspirations for all of us. And we want to improve the health outcomes of the country. With that, we are confronted with communicable and non-communicable diseases. And out of those non-communicable diseases, we agree and we acknowledge that RHD is a preventable disease. So the strategic thrust now of the current administration is to provide a comprehensive primary care service, bringing along all the necessary services nearer to the Filipinos, nearer to the community. And it's not an easy job, an easy task to be bringing the comprehensive primary care services, since we have around 28 million Filipinos needing the care of the government. And it's not
Spread
only
out
of the
across
government.
lots of islands as well.
Yes, and also maternal health concerns and neonatal, as well as cancer, TB, malnutrition, and these are the priority health programs of the country. Now we are bringing into the primary care facilities these services. And with that, we need to look into the patient as a whole individual using a life stage approach. So that's when they are in that facility, it's not on a problem-based assessment, but it's the whole person in itself. And this one is through the use of our policy, the Omnibus Health Guidelines. And we also would like to thank WHO for helping us came up with our strategic development plan for adult, elderly, and children. It's a strategic development plan for us to operationalize that these targets, these health outcomes will be addressed. Currently, the country is having a strong collaboration and partnership with the Philippine Heart Association and the Rheumatic Fever and RHD Foundation Incorporation. And right now we have a very good projects, and that's we target around 6,000 children, 5 to 15 years old, to be screened. And with that, we are being supported by the World Heart Federation. And we are receiving the ultrasound, cardiac ultrasound, so that in the primary care facilities, we could do active case finding by using the point of care cardiac ultrasounds. So we're so thankful with this kind of project that our international partner is providing us. And with that, we need to capacitate the healthcare workers, the primary care health workers, train them, and then provide a clinical pathway, a referral pathway, and provide access to medicines. And again, we cannot do that with the government alone, and we are working with our partners, with our local government units, with the Philippine Heart Associations and other stakeholders helping us deliver that kind of project.
Can you talk a little bit about what the main challenges are then that you need to overcome as a matter of urgency?
Yes, we are currently facing on the access. It's because we know we are in an archipelagic situation, geographical situation in the country. So we have a lot of geographically isolated, disadvantaged areas. And we also have that around 28 million people needing really a very good support from the government. So right now, as I heard the testimony of Anu earlier, that's when you are sick, it's really a health care financial catastrophe. So right now, with the help of the Philippine Heart Association and our local government units, we have this health insurance package to support these primary care facilities be accredited and be reimbursed so that it's a good healthcare financing to provide a continuous primary care services for patients having a rheumatic fever and rheumatic heart disease. So it's more on healthcare financing and also access. So that's why it's difficult for a patient to travel around 2 hours,
Yeah.
and sometimes you need to queue in a hospital since the capacity of that hospitals cannot accommodate that number of patients. So bringing now the screening and also the management of secondary prophylaxis in the primary care facilities would really cut that barrier in terms of access. So with that, we can identify readily that our rheumatic fever case and prevent complications through this kind of project. So with this, the government is fully committed to support and scale up this project across the country. And we also would like to share that the priority now of the current secretary and the current administration also is to uh, build and establish more urgent care facilities so that this patient that needed a specialized care can access to that. So we are targeting at least 28 by 28, but right now we have around 14 that kind of facilities.
It's great to hear your plans and your intentions, and it sounds like you've got a clear vision in mind. Thank you very
Yeah,
much
thank
indeed, Jenna. Great to speak with you. Professor Goma, what is the prevalence of RHD in Zambia? And do you think the risks, Jenna was talking about educating healthcare workers, do you think the risks are known among the public, the healthcare workers, the policymakers?
Yeah, well, thank you very much. Well, we don't know the exact prevalence of rheumatic heart disease. Right now, it's estimated to be about 0.1%, but really, we have not had detailed surveillance as such for us to know the exact prevalence of rheumatic heart disease. And most of the cases that we see are actually cases that show up in older age. I liked hearing about her being diagnosed at 11. We usually catch our people also 12 and thereabout. And yet we know that this is a problem that starts mostly in childhood. And we have a lot of communities where there's still a lot of crowding. In the cities, we still have large communities in high density, low economic income areas. And then we have villages which are really scattered, most of them, more than 20 kilometers away from the nearest health facility. And for some reason, most of the communities don't take sore throats as serious diseases. And so when a child has a sore throat, they have to really find reason for taking them to the clinic. But to some extent, you find that the health workers at the health center also don't take sore throats that seriously.
Yeah.
So there's an issue of diagnosis. And then there's an issue, obviously, of giving them the necessary antibiotics should they find, a sore throat that they suspect may be streptococcal. And then we also have a problem with the follow-up systems. And to some extent, the government is doing something now. We have just embarked on what the NCDI Poverty Commissions have termed the Pen Plus project, which tries to bring about systems for long-term follow-up for these people once you catch them, and also trying to bring echocardiography to be a point-of-care system that is still in very, very infant stages, so to say. Because so far, echocardiography has been a preserve of cardiologists. And for a population of 20 million in Zambia, we still have less than 15 cardiologists in the whole country. And less than, I think, 5 pediatric cardiologists. And one of them should have been here to talk for themselves as to what they are doing really in rheumatic heart disease. I'm on the adult side myself, and so I always blame them for not having done much for bringing the child to me at that stage. We still do not have well-established cardiac surgery systems. And so most of the patients who have rheumatic heart disease with serious valvular disease, we still have to send them out for surgery. We have started doing something now, but as I said, still very, very baby steps that are being taken.
So can I ask you, I mean, clearly under-resourcing, a lack of trained professional healthcare workers, surgeons, specialists, these are all huge problems in trying to implement the WHA resolution. So what kind of strategies are you looking at to help?
Well, I think for now, we are trying to embark, first of all, on education, starting at communities. Okay, the education of the health workers, and then trying to bring about the health system strengthening to make sure that we are able to do everything at every stage, be it detection, treatment, and long-term care, to make sure that we have as few of them as possible developing into serious valvular disease.
Thank you very much indeed, Professor. Let's turn our attention to Malawi, and I know Malawi has been at the forefront of many public health initiatives. What progress have you made towards the WHA resolution and trying to eradicate rheumatic heart disease?
Thank you very much. It's an honor for me to sit at this panel, and I thank the organizers. So indeed, Malawi as a nation is not spared from non-communicable diseases, which include also valvular heart disease from the effects of complicated strep, beta hemolytic strep. So as a country, so far what is happening now is recently we developed a health sector strategic plan 3, which will take us to 2030. And in that health sector strategic plan, we are focusing on a comprehensive approach with an integrated format and also patient-centered care, which will take us to communities and to help us implement preventive and promotive health services. So as I'm talking now, we have a program in place where every quarter we conduct camps, which we screen communities from various cardiovascular problems, and when they are identified, and those include patients with rheumatic heart disease, they proceed to repairs and various surgeries that are required. So we are doing that in support by partners. Norway is supporting us, and also we have got Adventist team. They also send some cardiologists who come and support us. In the second point is, as Malawi, we have revised our establishment of health workforce. So we have shifted some cadres with skills to the primary care level. So what we have done is cadres like family medicine, physicians, as well as clinical associates. These are the degree holders with BSc. So there is a shift of the cadres to move to the primary health care level, so that we are hoping they will help us appropriate diagnosis and timely referral of these patients with rheumatic heart disease. And as I'm talking now, Malawi has embarked on the training of family medicine, which started in 2015. And so far, 11 physicians have been trained, and 19 people are still in training. So we are pessimistic to move to the primary health care and prevent conditions through these family medicine physicians in the near future.
Yeah, you've got a lot of challenges. Can I ask, all of you have mentioned the importance of partnerships, either with international or within the country. What do you need? What does Malawi need to see more progress on eradicating RHD?
as a nation, with a 20 million population, still in the lower income level and the resource constraint, we are still at a stage where we need indeed partners to support us. So I think continued collaboration with several partners and even including donors, it will help to assist us. But at the same time, we are not just depending on partners. We have also embarked on another strategy where we have started our private-public partnerships. We want to start generating money in our country so that we can finance our own Ministry of Health. So that one is at an advanced stage, and so far some partners have shown interest to join the public sector to make sure we implement the strategy. So that's what we are doing. And lastly, we don't have a cardiologist in Malawi. The one we have is only a pediatric cardiologist.
Right.
So we are also looking for opportunities for support to send people to do cardiology so that we support on what we are doing currently on the ground.
Yeah, that sounds like a key problem that you're all suffering from. Thank you very much indeed, all of you, for sharing your insights. Please thank our speakers from Philippines, Zambia, and Malawi. All right. I am delighted to announce that we have two keynote speakers who are going to give us their very important overviews of the drive, the progress, the challenges in tackling RHD in their countries. Let me please welcome now to speak for us His Excellency Khaled Abdel Ghaffar, the Minister of Health and Population in Egypt. Thank you very much.
Thank you so much. I think this is an important subject, and it's a really pleasure for me and to join you in this important endeavor and organized about the rheumatic heart disease. And we have all to work about diseases that is preventable, because rheumatic heart disease is something that we can prevent. And unfortunately, it's affecting vulnerable groups, affecting socioeconomic standard of patients that they cannot afford to get the proper treatment. So this is a preventable and treatable disease. Having said that, I believe that just going to the figures and the evidence based in Egypt, based on recently published data in 2023, the prevalence of rheumatic heart disease in school children is 2.3%. And the most prevalent lesions are detected by electrocardiography was mitral regurgitation, and regurgitation affecting 29% of almost the definite rheumatic heart disease cases. We've done a lot of work, I think going back to 2004, when we had a very important partnership with the World Health Organization and trying to tackle this by having in one city a strategy for rheumatic heart disease. And we started since that time by increasing awareness and providing proper education to those under challenges, and trying to control and eradicating rheumatic heart disease by combating and preparing and presenting proper diagnosis especially for group A streptococcus infections. We do have a problem of illiteracy in Egypt, and we have a problem also with poverty. So tackling this issue was not just from the Ministry of Health, but I think illiteracy and poverty plays an important and pivotal role in diminishing the awareness level and ultimately contributing to the high prevalence of the disease, because we've noticed from our studies that we see a lot of open heart surgeries replacing damaged valves, especially in rural areas and relatively poor areas. This means that on those families, they don't have the proper awareness, and so they leave their children with a simple, treatable group-based streptococcus infections, and without knowing that this might end up by damaging the heart valves. So we find that is extensively prevalent in certain areas in the country, then we started to take measures. One of the important measures is what we call Haya Karima, which is decent lives, and this is the government response in doing that by reinforcing important directions for awareness and for early detection of such an important issue. So by improving the health in general and improving the lives of nearly 60 million Egyptians, by improving the water supply, the waste management, enhancing housing conditions, and certainly promoting education. And within the education, we have to implement the health determinants so that we can make sure that we reach and outreach those vulnerable groups enough to start helping them in early diagnosis and treatment. We also adopted a childhood screening campaign, which is very important because it affected millions of school children to detect anemia, obesity, and stunting at early stage. And this gave us a niche in approaching those school children, and including at that time clinical cardiac examination to detect if there is any significant abnormalities at that early age. So outreach to those kids and to the millions of children. We have 24 million at school level, at the primary or the basic education level, 24 million kids at that stage. And by having this huge screening campaign, we also managed to, within that campaign, to include cardiac examination with that. As regards to the Ministry of Health, and how do we respond to rheumatic heart disease? It started, as I said, a long time ago, and during that time with the WHO, we established, first we started in one center, and then we expanded to 30 model centers equipped with advanced imaging process and imaging technology, and most importantly with capacity building of the skilled healthcare workers and professionals so that they will be able to early detect, because it's not easy. And we all know that we can have the best equipments and the best screening, but if you don't have the proper personnel trained enough to detect and early detect rheumatic heart disease, then this will be a problem. We are blessed by having Sir Magdi Yaoub. He is the eminent cardiologist in Egypt, and he's Egyptian. That is, he's a world-class, famous, cardiac surgeon, and he's back to Egypt since I think now more than 10, 15 years. It's even more than that. And he had a very important center, which we call it Magdi Yaoub Center, in one of the Upper Egypt governorates, which is Aswan. And this is a center of excellence. And since his arrival back from the UK, I said maybe, I think it's more like 20 years now, he started building capacity for generations capable of doing extensive, sensitive cardiac surgeries, addressing conditions. Certainly, a big part of it was rheumatic heart disease and congenital heart anomalies at the same time. So through this flagship centers and other flagship centers in the country, we actively participated in various global research, and these efforts aim to develop an effective cooperation with other academia and universities. And certainly, we also adopting through our protective sector in the Ministry of Health, to trying to adopt an effective vaccine for streptococcus, group A streptococcus, and I think this will uncover the relationship between the generic and the genetic alterations of different cardiac diseases, because we also started a huge project which is called the Egyptian Genome Project. And Dr. Sir Magdi Yaoub has also a very important publication in this sector, because he's trying to look after the genetic makeup of those kids that exposed to congenital heart anomalies. So worth mentioning that it's not just the Center of Excellence in Aswan, but we also have a similar chain of centers in different universities and different departments. And now we have brilliant NGOs related centers going hand to hand with the government. And that's an also important sector, because it's not about the public or the private, but also the civil society has a lot to do. And we have also an important cardiac institute, which you call it the National Heart Institute, that we are trying, that it's around since the 60s, but now we are trying to build up a pediatric cardiac institute, and that's also very important because we do have the capacity to expand and innovate and encourage young generations to start being importantly involved in this sector. Finally, pediatric cardiac surgery in the world, not just in Egypt, is quite challenging, and often this is there is a long waiting list for kids waiting to be operated, and addressing this issue systematically with a comprehensive approach and with a different approach through best practice that we can share together with international organizations that, like the World Health Organization, will be of great help. So this is just to shed the light on the activities and the effort from Egypt about this important issue, which again, it could be preventable and it could be treatable. So we all have to work hard in order to prevent giving our young generation that burden of disease. And I thank you.
Thank you, Your Excellency. Thank you very much indeed for that view of the efforts across Egypt. And I'd like to extend a very warm welcome to the Minister of Health from Tunisia, His Excellency Ali Mrabet. We'd love to hear a few words from you as well. Thank you very much, sir.
Thank you very much, honorable guests, dear colleagues, ladies and gentlemen. My English isn't very good, excuse me. Yeah. Then I am honored to speak about the significant steps Tunisia that has taken to eradicate rheumatic heart disease, a condition that has long plagued our nation's health like many African countries. Tunisia, recognizing the burden of this disease, has implemented a multifaceted approach to eradicate it. Our health policy against rheumatic heart has begun in the early 60s, just after our country's independence in 1956. That means since 67 years. We set up a model of prevention of rheumatic fever with an intervention on the primary, secondary, and tertiary level. Firstly, Tunisia has strengthened its public health infrastructure, focusing on early detection and treatment of streptococcal throat infection by enhancing the capacity of primary healthcare centers. The country ensures that even the most remote communities have access to diagnostic service and essential antibiotics. This initiative has been crucial in preventing the initial infections that can lead to rheumatic fever and subsequently rheumatic heart disease. Secondly, Tunisia has launched extensive public awareness campaigns. These campaigns educate the population utilizing various media platforms from radio, television to social media. Another critical decision has been the integration of rheumatic heart disease prevention and control into Tunisia's national health strategy and plans. This integration includes routine training for healthcare professionals and particularly scholar medicine to screen and clinically recognize and manage streptococcal infections and rheumatic fever promptly at different stages. Moreover, Tunisia has invested in research and data collection to better understand the epidemiology of rheumatic disease in the country by establishing a national registry for rheumatic heart disease. In 1980, we noted that the importance of rheumatic rheumatic fever has considerably decreases. Tunisia has partnered with international organizations such as the World Health Organization, the World Health Federation, and various non-governmental organizations to bolster its rheumatic heart disease eradication initiatives. Finally, the Tunisian government has prioritized improving overall cardiovascular care by upgrading cardiac care facilities and training specialized healthcare providers. Tunisia ensures that those already affected by cardiovascular disease receive the necessary surgical and medical intervention to manage their condition and improve their quality of life. Thank you very much.
Thank you very much indeed, Your Excellency. And I have to disagree. I think your English was very good, certainly better than my Tunisian. On to panel number 2, and we are going to look now at how to best mobilize resources for tackling rheumatic heart disease, and we will have time for a couple of questions from the floor at the end, so do please have those ready. I'm delighted to introduce now Dr. Bernadette Dalmans, I do apologize, Unit Head of Child Health and Development at the World Health Organization. Please take this seat. And Professor Jonathan Karapetis, Executive Director of Telethon Kids Institute, which is a leading Australian research organisation that helps to improve the lives of kids and young people. And can I just say, it is a feat of endurance being on these stools, so do bear with us. Dr. Dalmans, thank you very much, both of you, for joining us, first of all. So let's talk about the WHO's broader initiatives in maternal, newborn, child, adolescent health. How does that contribute to easing the burden of rheumatic heart disease?
Thank you, Julia, for this question. And I'd like to start also by thanking the organizers for having invited us and the speakers that preceded for sharing such rich stories. It was really inspiring. Thank you. So in the World Health Organization, as my director, Dr. Banerjee, said already, we are trying to play our part, and it's the member states that are actually helping us to drive the agenda. The resolution in 2018 was key. And since then, there has been sustained effort to engage around the area of rheumatic heart disease. And in our department, that has a title of Maternal, Newborn, Child and Adolescent Health and Aging, we were given the responsibility to develop a guideline. A guideline in WHO is important because it's the basis of all the practice tools that can emanate from there that governments can use for strengthening their services. So why MNCH? Clearly, we have heard from the audience that rheumatic fever, the pathway towards this serious condition of rheumatic heart disease, starts in childhood. The incidence of rheumatic fever highest in children 10 to 14 years of age, with repeated incidents after. So if we want to do what the previous speaker says, to identify them early, we need to have a platform where that happens. MNCH services is one of them. I like to add that during pregnancy, rheumatic heart disease is the major cause of cardiac complications that a woman may face and that may lead to mortality in that period. So here we have another sort of opportunity as well as responsibility to act. So the guideline looks at these different perspectives and in particular focuses on primary and secondary prevention. Primary prevention through appropriate treatment of strep throat infections and skin infections. Secondary prevention, that once rheumatic fever has occurred, to prevent recurrence and progression to rheumatic heart disease, or when rheumatic heart disease there is, preventing the aggravation thereof. 16 recommendations that when the guideline comes out, we hope in August, some of you may say, well, we knew most of this already, because what you have been referring to in terms of what is happening in programs is echoed within this guideline. We are glad that there is a recommendation that kind of recommends handheld echocardiography as sort of a valid option for early detection of rheumatic fever carditis or rheumatic heart disease. It's also a means to do screening that then, when clients are identified with signs of illness, can be confirmed through more rigorous diagnostic tests. So overall, we have possibilities to move for using the MNCH platform when we see young children in services with illness to raise awareness about the caregiver to treat strep infections, as well as accompany older children, where we now see increasingly, and we've heard the examples, countries adopting school health services and school-based program where screening could take place.
I want to throw a challenge at you, though, because one of the things that a lot of LMICs talk about is the shortage of antibiotics. To prevent rheumatic fever, it's obviously quite a lengthy regimen. How is the WHO addressing that?
Yeah, so an important question. Benzyl penicillin, BPG in short, is indeed medicine essential. The guideline recommends that it's the preferred drug for secondary prevention of RF and RHD, and the supply is sparse of it. We can read it in the literature in relation to this condition. We can read it in relation to prevention of mother-to-child transmission of syphilis, for example. So we are discussing in WHO, we have a coalition of different departments working on this area, and so there are different means that the organization has for moving this forward. The first one is the essential list of medicines, where BPG is already a drug registered, but the emphasis on using it for rheumatic heart disease can be strengthened. So putting that specific indication within the list. To stimulate production, pre-qualification is an important process. I think it was tried by WHO for BPG in the past, but may need to be revitalized to invite manufacturers to actually engage with that process and increase manufacturing, because if I'm not mistaken, and the audience will sort of correct if I say it wrong, there are very few, possibly only one core manufacturer of BPG, and so there is really shortage on that. And then, of course, the organization has the technical capacity to accompany companies in the region or locally who take on this challenge of producing the BPG to ensure adequate quality criteria. I'm happy to say that in the audience, my colleague from the medicines department has joined us. So in the question and answers, we can get some more details around that. But this is certainly one of the bottlenecks that we need to seek to address.
Thank you very much indeed. Jonathan, if I may come to you. Telethon Kids Institute has initiated the End RHD program, which I believe brings together multiple research teams to tackle the many questions about RHD. How do you think research can practically advance efforts to control and prevent and eradicate RHD?
Thank you, Shirley. And let me also thank the World Heart Federation, and a particular shout out to the Heart Foundation of Australia, David Lloyd's up the back, who've such champions of the work to control rheumatic heart disease in Australia. I've been in research and clinical care and public health for rheumatic heart disease, particularly in Indigenous Australians, for about 30 years. And over a long period, we really tackled a lot of the different questions, unanswered questions, everything from unraveling the role of skin infections in causing rheumatic fever, unraveling the genetic basis of the disease, to then working on how to better diagnose rheumatic fever, how better to provide clinical care to people with rheumatic heart disease, through to how to empower health services to deliver penicillin. All of these things, we were bringing evidence to the table. We were trying to work alongside the health services. So back in 1997, when I was doing my PhD on this topic, I accompanied a member of the Northern Territory, in the northern part of Australia, Department of Health. We went down and got some funding for Australia's first register-based control programs. So we've been trying to put the research into action, but about 8-9 years ago, a consortium of researchers got together and said, we need to do better. We need to actually bring all the evidence to the table and to work alongside the health services, to work alongside people with lived experience, and to actually develop a blueprint for how we can eliminate this disease in Australia. And we actually used that word, to eliminate rheumatic heart disease, because if there's one country in the world that should be able to do it, it's ours.
Yeah.
As Minister Butler said, we're a rich country, and we've got this devastating epidemic of rheumatic heart disease that still is killing young Aboriginal Australians. So we did, over a 5-year period, we pulled together all the evidence into a blueprint. It's called the Endgame strategy. What we also did during that period was recognise that we were at risk of this information just sitting on the shelf if we didn't bring the people to the table who are going to be responsible for putting it into action. And so we partnered with the Aboriginal Community Controlled Health Organisations. We actually developed the End RHD Alliance. We got those people, those organisations to really inform all the recommendations. They're the ones who told us, stop just giving us medical solutions. This is a disease of the social determinants. That should be front and centre. And so it is in the Endgame strategy. It's about housing, it's about living conditions, it's about environmental health, as well as how to diagnose and treat rheumatic fever, rheumatic heart disease.
So all that data that you've now brought together, can that change policies? Can that influence resource allocation, funding?
Well, the great thing is that what's also happened since we released that was launched by the Minister for Health at the time. It is now in the hands of NACCHO, the National Aboriginal Community Controlled Health Organisation. They now partner with the Commonwealth Government to implement rheumatic heart disease control in this country. So that's exactly what, as a researcher, you want. You want it to be in the hands of the people who are delivering services. And now what we are doing as a research community is we are trying to be much better partners and allies. Partners and allies with the people who are delivering care on the ground. And what we need to do, and Anu needs to be at the front and centre of this, is we need the lived experience to really guide how the future heads. We're tackling a whole lot of really exciting stuff, and I'm happy to tell you about that as well. But we need to continue to be asking the people who are delivering care, who are making policy, what are the questions that actually drive you, rather than what are the questions that drive me as a researcher.
Jonathan, thank you very much. And Bernadette, I saw you nodding emphatically when Jonathan was talking about the fact that this is a disease that cuts across all different sectors, housing and social and socioeconomic factors. Financing was a big issue that a lot of member states are talking about when it comes to trying to implement that resolution. Are there any examples of effective investment strategies that might help, that might be used and replicated?
The issue of financing is indeed a delicate one, and I would say in the World Health Organization we have experienced it with the resolution, and the fact that the work has progressed slowly is due to the limited investment that we see also at our level. So if the global community wants change, change can happen. We only need to think about Gavi or the Global Fund, and we see what is possible, On a smaller scale, my director referred to it, there are WHO elimination strategies, cervical cancer, mother-to-child transmission of HIV, syphilis, hepatitis B. So these are examples where, particularly for the cervical cancer, member states stood up and asked WHO through a resolution to say, we need a strategy for how to tackle this. And so a roadmap was developed with specific targets, both for elimination of cervical cancer as well as for the 3 conditions that I said, that is now driving the work. So with the voice of the member state and with having a global action plan, resources are then being mobilized. Maybe not as large as we would like to have them. The pathways for these conditions are still quite modest in the way they can progress, but there is voice. So I would say within this community, we need to see what comes next. there was one resolution. How can we rally? And it's fantastic to see the partnership around, you know, the World Heart Federation, professional association, civil society. There's so much movement around it. So we need to raise voice and then work together to kind of get to the point where more investment is
Raising
available.
voices is so important. Advocacy is so important, as we saw from Anu, who was talking about that. I'm going to throw the money question at you as well. Innovations, technology, research, all of this has an important place in trying to control RHD. What are you excited about? Where does the research have to go? And do you think there's enough investment in that area?
You're asking a researcher if there's enough investment? Of course there is not enough investment. There is a graph. There is a graph that shows of all the neglected diseases. There's a graph that shows the burden of disease and the amount of R&D investment. The worst disease for investment relative to the burden is rheumatic heart disease by a long shot.
Wow.
Massive burden of disease, minimal investment in research. What's happening in the last few years as people are becoming aware of it, they were starting to see the dial change. Where's it changing? It's changing from philanthropy. It's not actually changing from industry. So philanthropy is getting behind. They're getting behind vaccine development. So there is now a global vaccine consortium, SAVAC, the Strep A Vaccine Global Consortium. And then in Australia, we have government funding for the Australian Strep A Vaccine Initiative, and we've supplemented that with funding from Open Philanthropy and the Leduc Foundation. So we are now getting funding behind what is really exciting vaccine development work. The Leduc Foundation has funded a global consortium to develop a diagnostic test for acute rheumatic fever. That's also very exciting work that's happening. We are developing new formulations of long-acting penicillin. That's funded by so far government funding, but we're trying to bring more philanthropy to the table, and we're excited by that. So it's being driven by people who care, by philanthropists, some governments, not enough governments. We need to get much more traditional funding to the table. The NIH convened a series of workshops a couple of years ago to identify a whole lot of priority questions for rheumatic heart disease control. Those papers have been published. We now need to see the dollars come to the table to fund it. So we need more funding because the researchers can come up with some really exciting solutions.
It's good to hear that you are excited and that there is a pathway forward. But yeah, we always need more money in research. Thank you very much, both of you, for the moment. But do stay where you are. I would like to take a couple of questions from the audience if anyone has anything they would like to ask our speakers. They've told you everything you want to know. Okay, yes, gentlemen there. Now, one of the problems is microphone. So you're going to have to use your big voice, your outside voice. Do you know what? I'm going to come over and hold the microphone to you, because thank you. I will.
I can hold it.
Okay, but I need to take it back because otherwise I won't be able to.
I will give it back. Yeah, I was saying that I'm Joseph Muchumbitsi from Rwanda, and it is one of the countries, of course, where rheumatic heart disease is still a problem. And the question I want to bring on the table is, you have spoken about funding, but when you see countries progressing, being able to run surgical programs, you have rheumatic heart disease never end. When you operate on a valve, you have seen Anu how she had 2 surgeries. Most of the time in our countries, you cannot get the chance to be operated twice. We have seen in the few patients we have reviewed, some young ladies who have chosen to have a non-mechanical valve have died years after because it's going to be calcified. And anticoagulation in our settings is really a difficult problem. So, but also access is still so limited that we just lose patients without being able to do something. In East Africa, they have talked about trying to have center of excellence. I built the center in Tanzania, But at the end of the day, patients from countries around cannot have access because it's still too expensive. So is there any strategy at global level to support those kind of centers of excellence? I know there is a group of surgeons or surgical societies who have brought that idea on the table like 2 years ago, but they were looking for funding, but it's still nowhere. Is there any hope around that? Thank you.
Thank you. Great question. And lack of facilities and specialist centres and trained cardiologists was one of the issues that came up. Do you want to take that?
Can I first go and then I'll hand it to you because
Sure.
WHO needs to sort this one out. Joseph, one thing that I'd ask everyone to just reflect on is that we have the heart societies, the heart foundations, the cardiologists and cardiac surgeons rightly are championing this cause, but inevitably you end up dealing with what you're facing, which is people dying of rheumatic heart disease. And your question goes to the heart about how do we stop that? What it doesn't go to the heart of is how do we stop new cases happening in the first place, which is where a lot of my research has been focused, because I have the benefit of being in a country where we have access to those heart conditions, those heart surgeons. And so I'm interested in how we also empower low-income countries, middle-income countries to look at prevention much more effectively. And indeed, what Minister Butler announced in terms of a centre of excellence in the Pacific will not be a surgical centre of excellence. It will be a centre of excellence around primary healthcare, public health control, secondary prevention. And obviously there is also the need to make sure we focus on the surgical side of things. So I do want to just make an appeal that we need to make sure we're also trying to stem the tide. Having said that, what you've said is incredibly important and WHO can solve it.
And for the magical answer, here we have.
I actually wanted to echo your words and say, of course, we need a system at all levels, but prevention is key. Many countries are now working universal health coverage, their primary healthcare packages. So integrating the right interventions at the right level of care can bring us on this pathway of prevention. Clearly, tertiary care is needed, and I think in every continent there are centers of excellence where we, through our work on the guideline, got exposed to colleagues in South Africa where high level. So at the country, in regional level, I think through our regional offices, there is also an opportunity to advance this conversation and see how exchange can happen. Do we eventually want every country to have a full-fledged system with all the care that is needed at each level? Yes. On the pathway to getting there, the analysis has shown that investments in secondary prevention is number one to focus for. Primary prevention is a bit more costly, long-term, and so forth. And as you are investing appropriately there, then progressively also build that expertise for the treatment that every individual has a right. So if you're affected seriously, clearly, you have a right for treatment on that also.
Thank you. Thank you very much. And with perfect timing, you have brought us to the end of the session. Thank you very much indeed for your insights. Thank you for your contributions. And please join me in thanking our speakers. Now, I think there are some refreshments. Please feel free to network and to mingle and to relax. And thank you very much indeed for your attention during this session.